And good morning. I'm Dr. Kim Allen Williams, and Chair of Medicine here at the University of Louisville, and it's my distinct pleasure to introduce one of my core leaders, Dr. Forrest Arnold, who is our Chief of Infectious Disease, and he's done so much for this university in these times of what I was just saying to him was kind of viral fatigue. We were just going one disease after another, and he's been in the midst of all of them. Forrest hails initially getting his BS in biochemistry from University of Tennessee. He then did Doctor of Osteopathy at West Virginia School of Osteopathic Medicine, internship at West Virginia University, residency at University of Tennessee, and then did his fellowship at University of Louisville. And he's been here really ever since, from fellowship, doing master's degree, working his way up from instructor to assistant professor, associate professor, and he's been a full professor since July of 2022, when he took over as the division director for infectious disease. He's been a great leader and has always been a great resource, and we love having infectious disease grand rounds. He's always entertaining. The infectious disease always shows up, and then he shows out. So looking forward to it. Thank you so much, Dr. Arnold.
Thank you. Good morning. I am happy to be here today and talking to you about avian influenza. I'm sure that you have heard about that in the news, and I have titled it Pandemic 2.0. The current CDC level of concern is officially low, but I want to make an argument that we should be especially aware of what's going on, and that this pandemic is probably going to happen at some point in the future. So I have no conflicts of interest. I am going to report some medications today, and when I veer off the FDA-approved indications, I'll let you know. My outline today is pathway to pandemic. So we will plow through the background and the risk factors and the clinical presentation and the infection prevention. But first, let's hear a case. 66-year-old male with comorbidities. Diabetes was a little out of control. COPD, still smoked, and he declined home O2. CHF wasn't too bad with the New York Heart Association of stage 2. He presented to his PCP with a 2-day complaint of sore throat, just other influenza-like symptoms. You know what they are. And then with infectious diseases, we always get to ask the fun stuff. You know, what are your hobbies and things? He was retired. He had backyard chickens, and he loved going on goose and duck hunting trips. So he had a fever in the ER. He had, low oxygen level, hypoxia. Other vital signs were fairly stable except for some tachycardia. And then they got a chest x-ray. On this thumbnail, let me blow it up for you. You'll see that there are indeed bilateral lower lobe infiltrates. You can see the main stem bronchus. You can see the right and left one, but the right one appears to extend further. And you're seeing an air bronchogram that's surrounded by that infiltrate. And so he indeed had pneumonia. He was admitted for that diagnosis, and then a rapid influenza test was positive. We'll go over testing later. He had a prolonged course of 3 weeks, then he decompensated, was transferred to the ICU, intubated, coded, and he died due to pneumonia caused, later known by H5N1 influenza A. If this sounds like the gentleman who just died last month in Louisiana with H5N1, I tried to emulate him. He has not been published that I know of in a case report. I've combed New England Journal and JAMA, but we do know some things, and some things about my case that I present here are true. We knew that he was over 65. He had comorbidities. He spent 3 weeks in the hospital. He did indeed die of H5N1, and then the CDC took his gene of influenza A and compared it to his backyard chickens, and there were only mutations in his, which they said suggested that the mutations emerged in the patient after infection. Interesting. So let's talk about some background of influenza. This is the virus. This cartoon makes it look a little bit like coronavirus, but it doesn't look like that. There are two proteins on the surface. One is hemagglutinin, and the other is neuraminidase. and they're enlarged here just so you can appreciate them. There are 8 strands of single-strand RNA, and then what I've blown up here on the right side is the virus, and this has a little bit of a complicated life cycle. It attaches to our cell with the hemagglutinin binding our sialic acid, so it makes a bond there that's pretty strong. Once it gets into our nucleus, there are some proteins made that come back into the nucleus from the cytoplasm to help, and that's what you're seeing here. Some of the viral RNA, you know, our DNA is transcribed to RNA, which is translated to proteins. This is RNA to start with. It's transcribed to mRNA and translated to proteins. So a little bit different. Anyway, this is viral RNA, and it's got 3 proteins that it made, PA, PB1, and PB2. But it needs 4 proteins to reproduce. So it steals our mRNA cap-dependent endonuclease to complete this life cycle. Okay, that's not very nice, but that's what happens. And then it's able to reproduce, and it formulates all the viruses and the new virus strands and the proteins at the surface, and it has a new virus that's ready to bud off into the environment. But hemagglutinin, hemagglutinin is doing its work again, binding to our sialic acid, and it won't let it go. And that's where I want to show you here. Excuse me. The green represents the hemagglutinin, and it's bound to our cell by this sialic acid. And so it can't be released into the environment, and that's what the neuraminidase is for, and it knocks off that bond between hemagglutinin and sialic acid, and then the virus is freed in the environment for you to sneeze out and give to somebody else. Okay? So let's go over the nomenclature. Here's how they're named. First, you have the type of influenza, the location it's isolated, Breivik mission, that's in Alaska, strain ID 1, the year isolated, 1918, and then H1N1. So this, and then the other ones are named similarly. So influenza A, where they were first isolated, the strain number, and the year isolated. So this one in Alaska is a little bit of a, it's not the year isolated. They did that in 1997. They didn't know about, they couldn't detect the genes back in 1918. So in 1997, the snow had melted enough in Breivik Mission, Alaska, that they were able to exhume this body through just a little bit of permafrost. They did a biopsy of her lung, and then they found the RNA virus of the original 1918 influenza, and they did the genotype, and then they had it. And so that was amazing. So it was really a 1918 virus found in 1997. Later that same year, we have H5N1 that began in Hong Kong so many years later. So then you see the bottom one, California, 2009, that's our swine flu that we all lived through. Again, H1N1, very similar genetically to that original 1918, just a different strain number. So we talk about how it changes over time. So a shift is just where you have an abrupt major change in the hemagglutinin and neuraminidase. So that's what happened in 1997 when you have this H5N1 instead of H1N1. And then the drift is a minor change in the gene that codes for hemagglutinin or neuraminidase, but it's just a change in the clade, so you get influenza A 2.3, 0.4, 0.4b. The gentleman in Louisiana that died had influenza A D 1.1. That was a different clade. If you look at all the, well, here, let me tell you what a clade is first. A clade has a influenza A that has a common node or ancestor. And then among that, you can have subclades, but it's all H5N1 or H1N1, and then you can have subclades. The one for H5N1 is rather complex. It looks like this. And you can see that there are a gazillion, really, strains of H5N1. They're grouped basically geographically, Chilean isolates, Peruvian isolates, some in the US even. These are all taken from birds. It is an avian influenza after all. It's been found all over the world, as you can see to the left. And this is just clade 2.3.4.4b. Now, I didn't want to pass up the opportunity to show you. I don't expect you to read these birds, but I want to show you what some of them are because you know them. In the upper right, you have a heron. Those hang out at Cherokee Park sometimes. There's a South American tern that looks all the world like a common tern. I've never been to South America, so I didn't have a picture of that. There's a black skimmer in the upper left, a pelican, which you can find at Land Between the Lakes, Kentucky. The only bird on this list that's from Kentucky actually is a red-tailed hawk, and here's a picture of one in Cherokee Park. A sanderling, looks like the beach. Again, I've seen one in Cherokee Park and gotten a picture. The only picture that's not mine is this rooster that looks like it ran into a couple buckets of paint. And it's a domestic bird that's found in Southeast Asia. It's actually called a Gallus gallus. And people take it and put it on their farms. And so there was one with avian influenza that was in Peru. And so it also had avian influenza. And you know all these birds migrate. And so the movement of this virus is worldwide. So this is also called highly pathogenic avian influenza. And it's based on molecular and pathogenic criteria. The virus infects birds' respiratory and GI tracts to cause high mortality. And it continues to evolve. So the case definition are fairly simple. A confirmed case is basically a person who's confirmed to have it by the CDC. And then a suspected case is what we used to call a case under investigation. Has a three-pronged definition. There's epidemiological factors, like do you have backyard chickens, clinical, influenza-like symptoms, and laboratory. And here the confirmatory laboratory results are unknown or pending. And then a probable case has that same three-pronged definition, but the laboratory test results do not provide a sufficient level of detail to confirm infection. So let's talk about the epidemiology and the history of H5N1. As I said, it was first diagnosed or found in 1997 in Hong Kong. Then there weren't any cases until 2003 when you had sporadic worldwide infections. There have been 939 cases worldwide, and that's as of December 31st. So now it's slightly more than that, in the 940s probably. Notice that 464 of them have died. That's a death rate of 49.4%, extremely high. Fortunately, the last several have not been that way, as we'll get into. Here are places where there have been human outbreaks in the world, and most of it is Southeast Asia, moving into Middle East and Europe. There's a big cluster around the Nigeria region, and the one in the United States is in Seattle, which happens to be where COVID entered the United States. So it seems to me that would be a place where I would set up some kind of surveillance because things come to us through Seattle. The CDC has field investigations and collaborations in other parts of the world. You see there's not one in Seattle, but the CDC is us, so they're all over the United States. But we have Southeast Asia, Vietnam, Cambodia, Thailand, China, and Nigeria. The CDC is set up, and those are great places to be as you look at this chart. The European CDC is also very proficient, and so maybe that's why they didn't concentrate in that area. So 2020, we first see the clade 2.3.4.4b. I don't expect you to remember that, but anyway, there's been an unprecedented geographic worldwide spread, and it's been in domestic and wild birds and farm animals. 2021, we see wild birds in North America for the first time. Then in 2022, U.S. has its first case, and that was in somebody who had fatigue while depopulating poultry. And the CDC feels that was more colonization than true infection. Then the next year, 2023, we didn't have any cases. 2024, we have livestock outbreaks, so more than 300 dairy cattle herds were involved. And there are sometimes thousands of cattle in one herd. So we're talking about thousands upon thousands of cattle that have been put down. Also goats, alpacas, and then in that last year, 65 human cases. And most of them, fortunately, had mild illness with conjunctivitis. And then they had their flu-like symptoms and got better. 23 were poultry farm workers. 40 were dairy farm workers who contracted it by contact, 14 had conjunctivitis, only 1 had respiratory illness, and all were offered oseltamivir, most people accepted, and nobody was hospitalized, so a mild disease. There's been a handful of people who had an unknown exposure after the CDC talked with them. One guy had comorbidities and a moderate respiratory illness, and he was even hospitalized. He recovered, discharged, and then they called him back and said, "You had bird flu." And so that does not work well for the hospital either, because they're called and said, "Hey, the patient that you had 3 days ago had bird flu," and then employee health needs to do a search to see, okay, who had what, when, what other patients were exposed. So this contact tracing gets complicated. 2025 opened up with our death of the gentleman in Louisiana, and I'm not sure we had an unknown exposure. Our grand total is 67, but it'll be 68 before too long, and that'll be an accurate number. So in general, you see that as time has progressed, the last 4 years, we've seen it in wild birds, and it was in mostly Southeast Asia. It moved to poultry, and that moved around the world, China, Chile, and Ecuador, then in livestock and infected milk, and then humans, and we have our first death, and it's causing a lot of conjunctivitis. So that's kind of the overall flow of that. Then I want to show you the epi curve, and in the United States, we had that little blip in 2022, if you can see it down here in the right-hand corner, and then we had several cases in 2024. Now, the best thing I can tell you about this curve is that you see the peak, but to the right of that, you see at least 3 bars where it's descending, as if this has come and gone. So we'll see, only the future will know. If you look at the entire world, here's what's happened. You see those first cases in Hong Kong in 1997. Then there was a period where we didn't see any. And then there's been several outbreaks. Most of those are in Southeast Asia until this large one, which was in Egypt. And again, it's just since 2015, last 10 years, it's been a case here or there until the United States, and we've had our own outbreak. So this is an important concept, and I want you to hear this, especially including you in the medicine room listening. I appreciate you dialing in. This is important. There's a difference between H5N1 and H3N2. H3N2 is our seasonal influenza that we see each year. About 2/3 of our flu is H3N2, 1/3 of it is H1N1 still every year. So H5N1 attacks poultry and birds, and they have mostly alpha-2,3 sialic acid receptors. And remember, the hemagglutinin binds the alpha-2,3 sialic acids. We, on the other hand, as humans, have alpha-2,6 sialic acid receptors. And so these are in our upper respiratory tract. But we also have some, and I probably overrepresented it with my green dots here, we have some alpha-2,3 sialic acid receptors in our lower lungs and our conjunctiva. So seasonal influenza A viruses bind preferentially to sialic acid receptors attached to glucose by alpha-2,6 linkages to us on epithelial cells prevalent in the upper respiratory tract in humans. Okay, well, they can bind our alpha-2,3 sialic acid receptors that are prevalent in lower respiratory tract in humans and in human conjunctiva. And I think that's why it has killed so many people in the past, because it's going deep into the lungs. In birds, it binds their respiratory and GI tracts, and in dairy cattle, their mammary tissues is where these receptors are. So raw milk has a high level of H5N1 virus in an infected cow. So this was an amazing find with the influenza hemagglutinin. This is a biochemical structure of hemagglutinin. And I have a question mark, bovine or human, and that's because these guys, this is what got my attention. A single mutation in bovine influenza H5N1 hemagglutinin switches specificity to human receptors. Okay, so we as a nation, we have some attention given to H5N1, but we're mostly kind of lackadaisical thinking about it. It's in the background. But look at this 226 there. That is a blow up. So this leucine 226, if it mutates, the predilection for birds suddenly leans to humans, okay? And if any of those other pink and blue molecules, amino acids, get mutated, then the predilection for humans is even stronger. So the way that perhaps we don't spend too much attention toward avian influenza hinges on this leucine 226 not mutating. That's it. As one of my faculty says, are you picking up what I'm laying down? We are just one molecule away from having a pandemic. And the best thing we can hope for in that pandemic, if it's transmitted easily human to human, is that it only causes conjunctivitis and not a 50% mortality, because our treatment is not very good. So let's talk about risk factors for H5N1. It's garnered from the people who have had bird flu before us, avian influenza. So those people who are exposed to infected poultry in their backyard or a live poultry market, industrial workers. So if they're touching their eyes and nose and mouth after coming into contact with feces, they're handling sick or dead animals. If they're exposed to infected wild birds, defeathering wild swans after you've hunted one perhaps, exposure to infected cattle, drinking raw milk, or when droplets touch the eyes or nose, breathing in dust or droplets that contain the virus, and sporadic non-sustained human-to-human transmission, which fortunately is very rare. So there are other things we know of. If you sleep on a pile of chickens, this might be a risk factor. Find somewhere else to sleep, right? Or if you're in a meat market that probably wouldn't pass inspection, yet another risk factor. But you don't have to go to China to have a risk factor for H5N1. You can just go to the Kentucky Fair. I love this picture. This kid is just doing what kids do. Some of this is on the parent, right? You can also have a backyard chickens and just feed them right out of your hands. So human-to-human cases is what we're concerned about. Fortunately, it's only happened in 5 countries and not more: China, Indonesia, Vietnam, Thailand, and Pakistan. So these occurred after prolonged unprotected close exposure to a symptomatic patient who was in the household or in the hospital, and it occurred without changes to the H5N1 virus. And none have been reported since 2007, which is also good. So let's talk about clinical presentation, probably the easiest part for you. It has a wide spectrum of clinical presentation, from the transient detection, perhaps in 2022, to asymptomatic. This girl, look at her, she's smiling. Then these younger people tend to have conjunctivitis, but in the older, it could be acute respiratory illness, severe pneumonia, or even death. So that's about as broad as you can get. It sounds a lot like COVID. So mild respiratory illness, it'll have an incubation period of 3 days, maybe 2 to 7, and then have your typical influenza-like symptoms, plus conjunctivitis, which occurs a day or two after exposure. On the other hand, pneumonia happens 5 to 7 days after onset, and you get the usual pneumonia symptoms with hypoxia, fever, and the like. You can see it on your x-rays. You can get laboratory abnormalities with high or low white count, and that says thrombocytopenia. Anyway, this is an actual person with avian influenza. She was 37, and you see her x-ray was getting worse. And one way my mentor had us think about this was, you have a pneumonia, you get respiratory failure and ARDS, and it progresses to organ failure, whether it be from kidneys, heart, or lung. That progresses to multi-organ failure, DIC, sepsis, shock, and then perhaps death. Now, one nice thing about avian influenza is it's not usually associated with a co-infection, another virus. And then we're pretty familiar with influenza A being associated with a post-infectious streptococcal infection, and then perhaps that's even worse than the flu was, or Staphylococcus aureus. So we look out for that. Now, what I want to do is a biopsy of this person's lung. And so let's go deep into this person's lung and look at this alveolus. And in here, you see what's represented in the cartoon with some yellow. That's the virus. So macrophages will respond to that. They'll release some cytokines, call in some white blood cells, and then more will show up. And pretty long, you have a whole infiltrate that's actually visible with thousands of alveoli on the X-ray as an infiltrate. There's going to be two types of symptoms here. Some are local, your cough, sputum, chest pain and the like, all kind of having to do with the pulmonary system. And then systemic symptoms, fever, white count changes, hypothermia or fever, and neutropenia. Then they have found H5N1 virus in these body fluids: blood, serum, plasma, rectal swab, feces, and CSF. Very interesting, and it goes different places. These are all in humans. So let's look at treatment for a second. You probably haven't reviewed the FDA-approved indication for oseltamivir. It's for mild and moderate influenza. So we're talking about people who may have severe pneumonia, and I'm already off the FDA-approved indications, okay? But we are talking about influenza A and oseltamivir. So this is a retrospective study. They compared people who had H5N1, who had oseltamivir, to those who just had supportive care. Those who had oseltamivir, the survival you see is about 60%, compared to those who didn't. On the left, it was 25%. And then they looked at the benefit of oseltamivir over time in the right figure, and you see that the relative risk, I outlined it in green, is well above 1 in the first 48 hours, and I think we're pretty familiar with giving oseltamivir, trying to do it within 48 hours. But there was actually a benefit all the way to day 8 that's still above a relative risk of 1 in these people. It wasn't until day 9 that you begin to see, okay, this oseltamivir is not a benefit. So that's something that's also a little different with H5N1, is that if you're late in giving the oseltamivir, it may be of benefit. Of course, these studies are small, but that's hopefully going to pan out to be true. So there's also something that they've looked at in this graph on the right with resistance. These are 8 people. 4 of them died, 4 of them lived, and you see the viral load is on the left, and so the lower is the blue people, and they lived. The right is where the viral load stayed high, and they noted oseltamivir resistance in 3 of them. Okay, so let's review oseltamivir mechanism of action. You remember when neuraminidase has to knock that bond between hemagglutinin and the sialic acid free. Well, oseltamivir binds the neuraminidase, so it can't do that. And so your formed influenza virus is just stuck on your surface and won't release into the environment. And that's how that works. Baloxavir is a newer drug. It's a 1 pill once drug, 80 milligrams for somebody who weighs 80 kilograms or more, and 40 milligrams if you weigh less than that. So it works in the nucleus. And remember when the viral RNA, they had to steal our mRNA, cap-dependent endonuclease? Well, it blocks that stealing of the cap so that it can't reproduce. It doesn't get that 4th part, which feels like a little justification that it's not stealing our mRNA to complete its task. Okay, so what if you combine these two? There's just simply no data about oseltamivir and baloxavir together. Maybe it makes common sense, seems like it would work, but it's definitely not a recommendation. What about for people that have prolonged shedding? Again, no data, and even the shedding data is not very good. And I've told you about possible resistance to oseltamivir, so we hope that doesn't pan out. So clinical management, you put these people in droplet isolation. I would imagine if the hospital knew they actually had H5N1, that they would be put in special precautions, which would be the gown and the gloves and the mask and the shields. So that's something that we would do. Oseltamivir is up to you. And if you do it, you're going off the FDA-approved indications. But I imagine you probably would, because otherwise you're just getting supportive care. There has been some work with adjunctive therapy. Hydrosteroids doesn't seem to help. It's even associated with prolonged viral shedding and possibly higher ventilator-associated pneumonia and death. There's other immunomodulators where there's a data gap. We don't know about interleukin-6 receptor blockers. Remember, we had those used for COVID, JAK inhibitors, other antiviral agents that are not for influenza but possibly could be used for H5N1. Those are all areas that need to be studied. So let's talk about infection prevention. So the progress, pathway to pandemic is what I've titled this. You start with your H5N1, and it's gone from birds to cattle now. And then if it makes it to swine, that's bad news, because that's how we got 2009 H1N1. When pigs get co-infected, then for some reason, the virus can rearrange, and the two different types of influenza can swap gene parts, and that's when you come up with new, worse mutations. And so then you have an outbreak in humans that can lead to a pandemic. So we want to stop this cycle here. And I think the first thing we can do is educate about risk factors. We talked about the risk factors earlier. The CDC has published quite a good document, and people can use it who have backyard chickens. People can use it who are in a large commercial poultry industry. And so those managers and people that work there, these are pretty thorough guidelines. I put a picture of this girl here. You can see that this is not an example of how these guidelines would tell you to milk a cow. There's no gloves, and as soon as this adult's hand lets go of that little girl's hand, it's going where her left hand is, right? And then, I'd hate to attribute an entire pandemic to this cute little girl. Okay, the second thing we can do is monitor H5N1 in animals and birds. And fortunately, the government is doing this. There's just a gazillion animals and birds to screen, right? So here is in the United States where there have been cattle found with H5N1. And so most of the states are the flatter states where you have ginormous herds. And so, it's not surprising to see Texas, California, and, flatter states, Michigan, Iowa, that kind of place. What you don't see is Kentucky on this map, which is good. We have had some animals found with H5N1, including a couple raccoons and another animal that looked like a ferret. I can't even remember the name of it, a musk, or I don't know. Anyway, they're here. And I'm sure they're going to, it's going to be more. It's just not in our cattle. If you're wondering how you screen a cow, this guy's looking for volunteer help. And you'd get a big swab and do it the same way as you do a human. I don't drink raw milk. If you needed another reason not to drink raw milk, I think this is a good one. Remember, the receptors are in the mammary glands of the cow, and if it has avian influenza, then the viral load in the milk is increased. Okay? So I don't want to put a dig in at the raw milk industry, but it is what it is. Okay, we need to encourage influenza vaccine. This is a problem since COVID because people have vaccine hesitancy. And the influenza A vaccine will work against H5N1. There is a specific H5N1 vaccine that the CD has in storage. And so if there's a pandemic, it'll release it. But there is still some protection with the regular flu vaccine that we all get. And so in Kentucky, this green line at the top is what percent of people got the influenza vaccine 2 years ago. The next year, it was a couple percent worse. And this year, it's a couple percent worse. We're down to about 22%. And you see that we're going in the wrong direction with our vaccination. So hopefully we can bring that up. And really it starts with you, the physician. You have a trust with your patient. And so if the patients try to trust the CDC and people at large, they're not going to do it. They're going to trust you before they trust them. So we have to lead the way in that regard. So we have to identify H5N1 in humans more rapidly. And so an interesting way to present this to you is as an argument, because people like to listen to people argue. But it's with the CDC and the state, and I really don't have a bad relationship with them. We have a good relationship with them. So for the mere entertainment value, let's just have this conversation. But as background, I want to tell you, how do you see influenza reported to you now? Okay, there is no test for H5N1 in the hospital. It comes back like this. And at the top, you see influenza A. If you have a point of care test, that's all you get. Influenza A, yes or no, not even what type. So the next line says H1, that's H1N1. So if you have somebody who's influenza A positive, H1N1 negative, and then the next line is H3N2. H3N2 negative, well, if it's not H3N2 or H1N1, which are the two most predominant influenzas we ever see, then it could be avian influenza. That's the patient that needs sent to the state and the CDC to be tested. Fortunately, it's super duper rare. We haven't even had somebody like that this season. So we haven't had to forward any of that. So here's Carrie Reed from the CDC, and she's talking about in this document about the fact that they can test for these people that are positive for flu A, negative for H1N1, negative for H3N2, but they have to do an extra H5N1 test to do it. And you see the phrases she's using. It's extra work. You have to set these samples aside, get them over to the health department. It's a burden, and they're reluctant to do it, but they'll do it. That was her final conclusion. It just doesn't instill a lot of confidence that, that this is going to get done. So that's where I kind of waved my hand. This is a cartoon of me in the years past. Anyway, we have our own infectious diseases lab that's CLIA certified, and we can do testing. We would just need to have samples so we could verify our instruments and the like. The director would probably tell me it's more complicated than that, and I think it is, but you get the idea. If we can do it, I think we could help, is all I'm saying. So we asked the state, and they said, we can identify H5N1 infections. Presumptive positives are essentially forwarded to the state, and they would go to them for confirmation. Okay, that's fine, but that's not what my question was. They're telling me, they're answering the question, what is the process for identifying H5N1? Really, I just want to know, can I help? Can we help? And so 2 days later, the CDC put out this health advisory that said within it, furthermore, expediting transport of such specimens to commercial laboratories for additional testing may also accelerate public health investigation of severe H5N1 cases. That tells me they don't have a contract with LabCorp or Quest or somebody like that to do the testing. Okay, LabCorp and Quest are like battleships. They don't steer quickly, and contracts are not made quickly. Whereas our lab is small, we can pivot quickly. There's only a few employees, and we have some instruments and we have talented people. So we could explore that and get it done. And so that's when I said, hey, we have a lab. And fortunately, as I said, I put this up as an argument. It's really not. We're talking with the state, and we're getting some answers. At this time, they're not overwhelmed with samples, and I believe it because we haven't even had one this year. But the benefit of our lab would be that you would find out the answer tomorrow instead of the answer 3 days after the patient is discharged from the hospital. And so that is a key element. That satisfies the patient's curiosity, but it satisfies the hospital in being able to manage a patient who has avian influenza in a ward of other sick patients. That is super important and worth the time. So that's why I keep pushing this and asking about it. All right, and I'm looking forward to my conversations with Dr. Wolf and the state because they've been really responsive, and I appreciate that. All right, so here's a new idea for our hospital that's going to come to pass, and Dr. Snyder started this, and I had an independent idea of the same thing, asked him about it, and he already had this. But so what this is you can have your viral report, the viral respiratory viral panel, put out in 3 different sections. And if your patient has a positive virus in the first tier, then they report that out, and they don't report the other 2 tiers, and they don't charge you. So that's called diagnostic stewardship. You get your answer without paying as much. And so if it's not in the first tier, then they go to the second tier. What's even better than this is we can rearrange the tiers. And so you can see what my comment was from this proposal, and that was to move influenza A H1N1 from tier 3 up to tier 1, because I want to know if there's H5N1, right? I want to know if it's flu A positive, H1N1 negative, and H3N1 and N2 negative. So that would imply that it might be. We can also change the tiers in mid-season. You see at the top, this says winter. So this past winter, we've had mycoplasma pneumonia be a kind of a mini epidemic. And so it currently was in tier 2. I would have moved that up and moved something else down that's not so prevalent. And again, that really helps. So each season, we would meet a couple weeks before and say, okay, what order do we want our viruses in? And we're going to try to put it so all the positives are in tier 1 every time. Okay, another thing we can do to prevent this pathway to pandemic is follow the CDC recommendations and the recommendations from the state. Our trust in the CDC is at an all-time low, but they are the ones that have the most experience. And they are the ones that, you know, they made mistakes, but they also learned a lot from the COVID pandemic. We deal with patients who tend to think of the pandemic like on a one-patient scenario. So if you say, well, you know, you have COVID, I want to give you remdesivir, they're thinking, well, my grandmother got remdesivir, so I'm not taking it because everybody who gets it dies. But, you know, we think of it with the multitude of people who got remdesivir, like how good is that drug? Is there a benefit of the outcomes when you look at everybody who received it? The CDC recommends masks. They recommended social distancing. You know, when you have influenza, it gets on droplets when it's expelled from you, and those droplets tend to fall in a 3-foot radius, hence the 6-foot social distancing that we had during COVID. It was not just a number that they got out of anywhere. It's based on that 3-foot radius around people. So there is some science behind that, and the CDC in that sense has some good directions, and they certainly have a lot of resources and mean well. So that's something. I want to show you, one of the recommendations was to wear a mask. So this is the last several years of influenza in the United States. And if you look at the year of COVID, is primarily 2020, 2021, you see where it is. No, you don't see where it is. We were wearing masks and doing social distancing. It's buried down here on the bottom line. That PPE works. And that was one of the recommendations from the CDC that they should get credit for. People are quick to, you know, give them credit for all the mistakes they made. But wow, now that you look at the graph, you can see the blue line hugging the bottom all the way across. It was like an absent epidemic. And every year we have influenza A epidemic, except for that year when we were doing social distancing and wearing masks. Okay, the last thing we can do is invest in our health department. And they need resources to do testing, contact tracing, and reporting. And so they also fill up health departments across the state, not just in Frankfurt. And so that also needs resources. And so I would encourage them to have that kind of support. I want to also make you aware that H5N1 is not the only avian influenza. There's these other hemagglutinin neuraminidase numbers. And so I just had time to go over H5N1 today. You see that they also have a broad spectrum of disease. Some cause more conjunctivitis and just uncomplicated things, and some are more severe and have fatal outcomes even. Some do the gamut like H5N1. But just realize that there's more avian influenza out there than H5N1. I've just kind of limited my talk to that today. Okay, so I told you at the beginning that the current threat of H5N1 pandemic is low, and it is, and that's because H5N1 is a zoonotic disease that's transmitted between birds and animals, and there's only been a handful of human-to-human cases documented. The most recent severity is lower than in past years, so all that is good. But I also want to remind you that, you know, we have plenty of infected birds. We have plenty of infected cattle. We have plenty of swine and we have plenty of people. There is an overwhelming number of animals and birds to screen, and there's a finite amount of vaccine. The laboratory identification is slow, and the trust in the CDC is at an all-time low. And so I think we're set up for pandemic 2.0. I want to acknowledge several people. Tim Uyeki gave a fantastic talk at our Infectious Diseases Society of America this year on avian influenza, and that was very helpful. We also have our laboratory where Dr. Wolf and Dr. Maramuthu work, and they have been very helpful for this. My UofL ID clinical faculty contributed to this lecture, and then Dr. James Snyder, the director of microbiology at the hospital, is also helpful. And so this collaboration is fantastic. And so with that, I will take questions.
That's really fantastic. It's a lot of information that we all need to, there should be no such thing as viral fatigue. We should all be paying attention every time this happens. So one of the interesting things that you mentioned is that there is a vaccine, there is a government stockpile. What's going to be their criteria for release? I mean, it's supposedly for people who are at high risk. How are you going to identify those people? Is it just age?
Yeah, there's nothing published, and I have on the ID, infectious diseases kind of inside track, they haven't discussed it. So it'll probably depend on, how big of an epidemic it is. I would imagine that they would give it to an epidemic that's maybe at a farm or a poultry industry place. And so, like, if there's a bunch of workers that have it, then the other coworkers would also get it, because there's not nearly enough to go around the whole United States. And so they're probably going to just act fast when there's an epidemic in a small facility like that. That would be what I imagine. Yes.
Great talk, and my one or two questions about the chances of having pandemic 2 is increasing day by day. All the recommendations what we had during COVID were released to the publics, but we still lost millions of people. Unlike COVID, influenza infects more younger generation. COVID infected mostly the people who had underlying conditions or who were over aging population. So COVID brought the disaster. If this happens, we will lose 50% of the world populations if we are not fully prepared. The vaccine stockpiles, there are comparative analysis we do. mRNA vaccines were kind of rolled out so fast because they were synthetic. What about the H5N1 vaccine production at an emergency level? If we need to go, how much time it will take to ramp up the production to cover the people? The second question is, if it is already happening, almost all the states, diagnostic is a problem, I know, but why we are not vaccinating the dairy workers or poultry workers? Thank you.
Okay. So when there is a pandemic, I'm going to say when, I don't know if it's going to be 2026 or 2036, and the mortality has been 50% until last year when it dropped dramatically with the conjunctivitis. So I would hope going forward that we get that more milder version. And then if you remember during COVID, they instituted precautions to flatten the curve, because you can't really prevent everyone who's going to get it. You can just try to prevent them from all getting it at the same time when the resources are limited. And then I have no knowledge of the vaccines and how fast they can produce them and that kind of thing. But I'm sure we'll hear about it later if it gets to be relevant. I wish I did. I wish I was visiting from the CDC, but I'm not. Somebody else? Or Jason, is there somebody online?
Okay, so the first question comes from Dr. Emmons in BMT in hematology, and he wants to know, he said, you mentioned that the government is monitoring, but with the travel restriction for all branches of federal government, is any monitoring currently being done by CDC? Are we really monitoring this epidemic currently, and will the feds take this seriously in months to come? Should Kentucky be doing more surveillance of animals in communities?
In communities. Okay, so I hope that just as our NIH grants and all that is still going because the freeze has been frozen temporarily, that they're still screening animals for H5N1. And I do believe that it's a priority of the current administration. I can tell you, if I'm chosen to be the director of the Department of Health and Human Services, I'm going to Washington, D.C. I'll be back. Okay, and then I'll have more of an influence over priorities like this, where we do need to keep screening. And you got to be prepared for something like this, because, and if any president knows getting behind a pandemic, you got to stay ahead of it. It's this one, since he was around during the first one.
Another question.
I'll just answer the second part. Yes, we should be screening in Kentucky, and apparently they are more than cattle, which is good. We just certainly need to be continuing that, but don't need to think, oh, that's just a deer, they don't get flu, or I don't know. Some veterinarian person needs to be in on that. And I can tell you the veterinary literature, because I was reviewing that for this talk as well, is very good. And it's up to date. It gives me some confidence about that whole side of the influenza and animals.
Okay, another question. This is actually from Dr. Lori Earnshaw, who used to be with us in our internal medicine group. She says, I wonder what Dr. Arnold would say about how we might engage in preventative practices in anticipation of an outbreak. What do you think about what do you think about the new laboratory at the UPS campus? Will this make us a major specimen processing site for future pandemics?
Okay, so the guidelines I shared about what to do even if you have backyard chickens, I think is useful for the first part. And then one challenge to giving a talk on something that's a current event is you can't read enough. And so I don't know about that place at UPS, but that sounds interesting. Maybe we would be. We're certainly a central hub. If you look at Google Maps and see how many planes are there for commercial flights and compare it to the number of UPS airplanes, UPS has got 5 times more planes there. And it seems like there's a lot of planes for commercials, but it's not as many as you think.
And one more from Dr. Emmons. He wants to know who is furthest along in the T-cell vaccine approach to a universal vaccine for influenza viruses similar to the Oregon research. How far away is this goal?
Okay, T-cell, I'm not sure. I do know they're working on a messenger RNA, mRNA vaccine for influenza H5N1, but there's about 4 drug companies that have the protein-based vaccines, and they're already done. That's what they have stockpiled in. And so the market for the mRNA vaccine for avian influenza is probably not going to do much. And that's all I can say about the vaccines.
Anyone else have a?
Okay.
Well, thank you again. This was very eye-opening, and hopefully we will not get that mutation that makes human-to-human transmission a very likely and prevalent problem. Thank you so much, and we will switch over to the Cardinal Minute.
Okay, great. Thank you all for coming.